So, respected Ramanjit Ma'am, Pandav Sir, Dr. Devang, Dr. Julie, and all the members. As this is important topic, as told by our respected faculty. So, what is the normal IOP in pediatric age group? I will just say a few things. Why it is, whether it is different from adult or is it the same target IOP, or what is the normal IOP? Basically, I will start. So IF in children age, IF is still the main risk factor for progression of glaucoma. Accurate measurement of IF is crucial in diagnosis management, as all you know. And as the visual field testing is often impossible in the pediatric population less than 5 years of old, and optic nerve sometimes not visible through a cloudy cornea. So IOP plays an important role in diagnosis and management. And in babies or small children, IOP measurements are problematic, impossible in slit lamp, and so sometimes we do under general anesthesia. So I've been children, not same age in adult. I will discuss later and throughout my presentation, because it is different in different age group. Because as Dr. Pandav told, the ocular growth occurs since birth to nearly about 13, 14 years, and they have low sclera rigidity. They have elastic sclera. They have different corneal viscoelastic property, like in term of corneal hysteresis, corneal resistance factor, etc. And they have different cecity also from birth, slightly in higher range, especially in congenital syndrome and anomalies. The range increased to 630, 670, 70, 700 like that. And so this is different from adult. And what is the exact method to measure the IOP in children? I will discuss on that. And what instrument is the ideal for measurement of IOP? I will focus on these factors. So age told, pediatric eye, child growth, the weight of the eyeball doubles from 3 to 7.5 gram in adult, and the average axial length is 16.5 in newborn eye, and it increases to 22 to 24.5 like normal in approximately after 13 years. So if in a different rapid phase, 0 to 2 years, second phase 2 to 5 years, and third phase is 5 to 13 years, etc. Corneal curvature, you should know that the corneal curvature is not the same 43, 44 diopter in children. It is rather 40 in higher range, like 47, 48 diopter, and it all comes to adult value in approximately as around 3 years, etc. And the infant, the sclera is much more flexible as compared to adults, and the strength is approximately half. And if you see the thickness, 0.45 millimeter to 0.5 millimeter thickness, that is almost half of the adult sclera, that is 1 millimeter. So as I want to say that as some of the parameters, these parameters will depend on the tonometry. The tonometry depends on these parameters. Till now, no tonometry has it is independent of these variables. So definitely the IOP should not be same to the adult eye. And coming to the method of measurement, as you know, the children are difficult to examine. So we do most of the time under general anesthesia, at the term examination under anesthesia. So anesthetic agent depends on the agent. What agent we are using, maximum they decrease the IOP, except some few, and the timing of measurement, because there are 4 phases: just sedations, before sedation, at the time of intubation, deep anesthesia, at the time of extubations. So just after the sedation, before intubation, if you measure the IOP, that is the ideal method. What we do usually in the rapid center examination anesthesia, then you can measure all the corneal diameter, the fundus evaluation we should do. And you should remember that at the time of intubation and the extubation, the IOP increases due to sympathetic overactivity, and the endotracheal intubation is have more effect than the laryngeal mask airway, LMA. So if possible, if we can do under LMA, then that is better. Then endotracheal intubation. And topical anesthesia, the propionate, etc. we use for if the child is slightly cooperative, etc. that is better. And in office procedure like in OPD, etc. you can use chloral hydrate, because it doesn't affect the IOP readings. And one important thing I want to speak, that we should know that maximum times in examination anesthesia people use the speculum. But if at the during time of the measurement IOP, if you can use, if you can just spread out the leads with fingers and take the IOP, that will be better, because with speculum it increases the IOP up to 4 millimeter mercury, what literature says. And you can see here, these are the anesthetic agents. Just I am just focusing on the chloral hydrate, has no effect on IOP, and these are all the gases like halogen, nitrous oxide, all the and fluorines, except sevoflurane, they all decrease the IOP. And these are the ketamine, succinylcholine, they increases the IOP. So we should know that what agents we are using, what anesthesia people, what they have used for the induction or sedation. So that knowledge we should have. And coming to the measuring tools, there are many research papers from since 30-40 years. They're using various, they're comparing with all the tonometers, etc. So what throughout the literature, what I found, and we have practically experienced, that apprehension tonometry is stood amongst all till now the gold standard, even in children, because it is less influenced by the rigidity of the sclera, as only 0.5 microliter of the aqueous is only displaced. So that's why gold apprehension tonometry, if possible, is quite accurate and reproducible. Also, if you know that, you know all, if used in proper technique, proper way. And indentation tonometry displays large volume, so can be a large volume of aqueous, so can be affected by low rigidity of sclera, so causing false low IOP. And tonopen, there are many papers have come with tonopen, etc., because it is very rapid. You can take with children. But tonopen although act as a apprehension tonometry, but however, tonopen tends to overestimate the IOP in infants, so its usefulness in congenital glaucoma screening and monitoring is somewhat limited. And it is not that the intra and inter observer bias are also there, and outside the range they don't work as well like apprehension tonometry. And other tonometry, just to focus, pneumatic tonometry, it is a hybrid technique of apprehension and indentation tonometry. They are usually, if there is scarring of the cornea, irregular edematous cornea. But here again, the repeatability questionable. And there is the impact rebound tonometer, eye care, although not require anesthesia, but again, it is an indentation tonometer, replaces more aqueous affected by the scleral rigidity. Transpalpable tonometry, ProView has come, although has some benefit, but again, by it affected by scleral rigidity, thickness of the eyelid, because you do is here the through eyelid, eyelid, and orbicular stone and interpupillary scarring. The newer one, the dynamic contour tonometry, although promising results, as it doesn't dependent on the cecity or contour of and rigidity, but takes that time, like 8 seconds almost in children difficult, and it need to be more practical in children. So among these, what I want to conclude, apprehension tonometry is still now the gold standard for the children. And if you say, what is the IOP of newborn? You say, here you can say, these are the various papers. I have taken this from my International Journal of Ophthalmology 2014. There is a table. You can see this apprehension tonometry, they have run topical. These are all on the newborns only. They are 11, 13 millimeter mercury. But when you see the other researchers, they indentation tonometry 25, 21, again 16. There is a high much variability among these. So still it is more favoring on apprehension tonometry. And just I have taken this from IJO of Dr. Shiyota's article. You can see this is the IOP in adult. Adult will see the average. All know that 10 to 21 millimeter mercury. It is just theoretical for the literature of statistical result. But this is 14, 15 on an average, 16, 17, 18. This is the average IOP of adult population throughout this all the study. So definitely the children's IOP will not like that, not will 14, 15, 16 like that. This is from Baker Saffers, that is, they got test for glaucoma. I have taken a table. You can see this Perkins tonometry, they have various in less than 1 year, they have even 5 millimeter mercury, 6, 7, in cases of 13, 15, 16 years. So that means they less than 10, etc., like in the younger kid. And there are many papers, but I have selected one paper to put here because this paper, they work is from RP Center by, again, Dr. Ramanjit, Dr. Devan Tulli, etc., Dr. Tanutada and Binesha. They have taken actually 405 children of 810 eyes they have examined from 0 to 12 years, and through the Perkins tonometry, what they found, the IOP is almost up to 12 millimeter mercury, that is in children. And it tends to approach adult level by 12 years. They got series of that is year wise. They conclude that IOP in children is much lower than the adults. It was not to increase according to age if there is hyperopia, central corneal thickness. So it changes the IOP. But around 12 with that IOP, they found in so much large sample population of newborn to up to 12 years. This was the largest study what I found in literature. And so my conclusion like this, to neonate to 6 months, around 8 to 10, less than 10, I'll say, and 6 months to 12, 10 to 12 years, around 10 to 12 millimeter mercury. And there is a formula in literature I got found. Another formula to up to age 10, you can say that 0.71 into age in years plus 10. That means if the age of child is 3.
I think we get the thing that it's generally 10 to 12, Bhagavat. I think you're overshooting time.
Okay, ma'am.
So I think let's just...
Yeah, I'm just concluding. So 10 to 12 meter is the normal life range of newborn, and if it's 10 to get adult level by the age of 12, Goldman approach determine the gold standard for the assessment with least intra and inter-observed variability. When GET is not possible, Parkinson-Tonophen eye care can be used in the descending order of accuracy. And topical anesthesia with the speculum, if possible, the ideal. And CCT measurement, if possible, should be done because for the better IF estimation and correlations. And these are my references I have gone through. And thank you for your kind listening and attention.